Assalamualaikum everyone. Hello everyone. Good evening. Welcome to this session. MRCOG1, Physiology of Pregnancy, very important topic for the exam. I'm Dr. Mehwish with you. I hope everyone is doing well in the studies and it's 15th October today and your exam is 21st January, right? 21st January 2025. So I wish everyone is preparing good because if you are preparing good, then there are high chances that you can clear your exam. Guys, please just join the meeting and further don't do anything. Don't use the tools and just turn off the mics and that's all. So a lot of students have joined and now I'm starting. As I'm telling you, please tell me voice and screen is okay so we can start. Welcome, doctor. Yes, can we start? Is everything okay? The screen is okay. Okay, this session was meant to be conducted for the course students only, but other students requested to join, so I made it public. Guys, this is very important topic. The topic physiology of pregnancy is actually about changes which occur after pregnancy, and these changes are physiological changes. These are normal changes in if the changes are happening without pregnancy, we can call them diseases, but actually this is normal physiological change in the body of a female who is experiencing a normal pregnancy, so we call them normal changes. And the body after pregnancy resumes and the body then becomes totally normal, just like a non-pregnant person. So we start with this subtopics outline. You will read cardiovascular, respiratory, GIT, and urinary system changes. These are the most important ones. Hematological changes, and a lot of questions are from this topic only. Changes in the breast, very important topic. I have provided you physiology and endocrinology of the lactation, right? So it covers both. Changes in the uterus, the size and other things, and also changes in the skin. Everything is very important, and I've told you that you should make a good concept whenever you are trying to learn something. Here, what is the concept? You should understand that what is the root cause of these changes? What is the root cause of these changes? So the first thing is endocrinology. First thing is endocrinology. See, we are studying physiology of pregnancy, but hormones are affecting the body of the female. Hormones of the pregnancy are affecting the body of the female. And so I'm saying that you should know both physiology and endocrinology both at a time. So role of placenta is the first thing because you know there is a female and she is pregnant now and placenta is an addition into her body. Okay, placenta is an addition into her body other than fetus. This placenta is also a pregnant product of the pregnancy, so it is playing a role. What role? The major role it's playing in making the female body change. It's giving you the hormones. Okay, HCG, progesterone, estrogen, a lot of hormones, they are coming from the placenta and they are taking part in making the female body, actually turning the female body into a pregnant one. And then other changes are coming because of the role of the enlarged uterus. Why uterus is enlarged? Because it is containing a baby inside. Okay, so you can say that hormonal changes and pressure effects of gravid uterus by taking up space in mother's body. Guys, again, it's a request to keep your mics mute. Thank you. So two factors are combining and giving you normal physiological changes in all the systems in the body. And important ones I have already listed here. From these systems, they ask a lot of questions. And actually, physiology is more about, in MRCOG 1, the physiology is more about knowing what changes are there in the body rather than knowing that which thing is like normal. Like I would say, if you are learning cardiovascular system and you learn normal cardiovascular system a lot and a lot, or I should say non-pregnant cardiovascular system a lot and a lot, and you ignore the changes which occur in the body during pregnancy, you can miss a lot of questions because they are going to ask more questions from the changes in the pregnancy. So let's start. This is a wonderful table. I haven't made it actually. I've taken a screenshot from Essential Revision Guide. How many of you read Essential Revision Guide as a routine? Tell me. Chat box is open, or else you can open the mic and talk. Okay, good. And what's your name, doctor? Because I requested everyone to join with their names. Yes, what's your name? Okay, Sana, welcome in the session. You read Essential Revision Guide and you're also the course student. So I was expecting that course students will not waste time on the books. Instead, they can save time. Yes, they can save their time because this book is actually taking a lot of time. Okay, that's totally fine. I was waiting for one student to say that I don't read Essential Revision Guide. It's totally normal, guys. It's totally normal. That if you are not reading this book, that's totally fine. This book is huge one. We used to call it a big book. If you ask my friends who used to study with me, we used to call it big blue book. This is huge one, and trust me, it has a lot of information, which is so deep that the examiner is not interested in asking you that much difficult and difficult kind of questions. So what I do, I make notes. I pick important things from Essential Revision Guide and the other one, revision notes. And what I do, I combine them in a way that it's easy and totally easy to understand for the students. And I share the notes daily with the students. So this is a good table, I can say. This is a very good table. You can see that they have mentioned increase and decrease both. You will learn this table by heart. I'm again mentioning that this is very important. So blood volume, they are saying 30% it will increase. Plasma volume, you know that blood volume and plasma volume both are different. 45% it's increased. Red blood cell volume is also 20 to 30% increased. Cardiac output, again 40% increased. Stroke volume, 30%. Now we will stop here. We are seeing a lot of values only between 30 to 50%. If we want to learn this table by heart and we don't want to spend a lot of time on it, we have to be smart. Okay? So we are acting smart now. How we are going to act smart now? We're stopping here and we are memorizing that, okay, this is 40, this is 45. Are now learning the ranges. 30, similar one, 30, similar one, 30, similar one. Okay? So this way, now we are learning that blood volume, red cell blood volume, and stroke volume, they all are 30. Okay? Three values we have memorized. Other two, cardiac output and plasma volume. They are around 40 to 45. If you memorize this way, you will not forget. Then you look for another thing which is around 30 to 50. Okay, oxygen consumption, it is increased and it's 30 to 50 milliliter per minute increased. Now, what values are less than 30? Less than 30. Okay, we are seeing 10% here and it's heart rate. Heart rate should not be so much increased because it will give the patient palpitations and a lot of other disease or symptoms. So it's a bit increased. So it's making sense. Heart rate is 10%. And how much blood pressure is taking part? 10 millimeter Hg decrease in diastolic and 5 millimeter Hg decrease in systolic. There is a detail mentioned about the blood pressure in further slide, so I will show you. Also, guys, peripheral resistance is also decreased. Please tell me why peripheral resistance is decreased during pregnancy. What do you say? Yes. Why peripheral resistance is decreased during pregnancy? What do you say? Any idea? Anyone? Okay. We will try finding answer to this. Somebody has answered. I want to check. Mm-mm. Dr. Bishop, very simple answer is vasodilation. Very good, Dr. Miralam. Very simple answer is vasodilation. Other factors also contribute. Okay, now, now they have given the detail in Oxford, sorry, the Essential Revision Guide. So I've mentioned the detail as well. 40% we have learned it will rise 4.5 liter per minute to approximately 6 liter per minute. So they can ask you this way as well. Okay, they can ask you this way. They can ask you this in the MCQ, sorry, SPA. So begins early in pregnancy, peak at about 24 to 30 weeks. So I believe this can't be a question in exam. It was never asked this way in the exam, but it's a good knowledge, so you should gain it. Now, an MRCOG student is curious to know why cardiac output is increased. Okay, an MRCOG student is curious. He wants to gain more knowledge. So they are saying that uterus, kidney, skin, and other organs, they are taking up around the term a lot of blood. As 300 to the kidneys, 500 to the skin, and other organs like GI tract and breast, and other 300. Okay, so it's taking up. So the cardiac output, which is increased, is divided this way. So cardiac output, what happens after delivery? It decreases. Most reduction in the first 6 weeks, but full recovery may take few months. Okay. When you read the detail of something, there are higher chances that you don't forget the important points. What happens with the stroke volume, guys? So stroke volume increases by 30. We have just learned heart rate by 10 from 80 to 90 beats per minute. 80 is normal. It can rise up to 90. Blood pressure we have learned diastolic 10 millimeter Hg decrease and systolic is decreased by 5 millimeter Hg. Peripheral vascular resistance, it is decreasing due to vasodilatory effects of progesterone, which is the hormone of the pregnancy, and there is a rise in nitric oxide and prostaglandins and lower asymmetrical dimethylarginine levels. Okay, oxygen consumption, we have learned that it is increased 30 to 50 ml per minute. What is spine hypotensive syndrome? My course students are well prepared about CVS changes in the pregnancy. Please tell me, what is spine hypotensive syndrome? Yes, use the chat box. It's written in front of you, but I want you to contribute in the session. Okay. If you know about the syndrome, very good. If you don't know, just open the notes and read. Good. Compression of the major vein in the body, inferior vena cava, which is lying behind the gravid uterus. And the gravid uterus can compress the vena cava. It's a temporary thing. So what happens? Very low blood pressure and dizziness and faintness and nausea. And how patient can handle this? She can just turn to the lateral. Moving from supine to lateral position restores the blood flow. That's all. Release the pressure. Exactly. We ask the patients to lie left lateral as a routine. If they are in their homes, they should lie left lateral position as the safe most position during the pregnancy, especially in the third trimester. They are also mentioning electrocardiographic changes. Heart rate, we have decided that increases by 10 to 15% normal. Left axis deviation is normal in the pregnancy. How much? 15 degrees. Why? Always ask yourself why something is happening due to upward displacement of the diaphragm. Upward displacement. And why upward displacement? I've told you pregnancy is mixture of two changes only, endocrine changes and pressure changes. Okay. So this diaphragm uplifting is due to the pressure coming from the uterus. Okay. Inverted T wave in lead 3, Q wave in lead 3, and AVF is also a common ECG change during the pregnancy. And now we are going to talk about hematological changes in the pregnancy. This is a long topic given in Essential Revision Guide, so I have summarized it in a way and I have presented in a way that it's easy to understand. So let's talk about the plasma volume expansion. We have already learned from the table that it's 45% from 2600 ml to 3800 ml. Learn these values as well. Okay, learn these values as well. Begins early in pregnancy, around 6 to 8 weeks it started and peaking at 32 weeks. Plasma expansion. And what happens after this plasma volume expansion? Physiological anemia is common. Physiological anemia during pregnancy is common due to disproportionate increase in plasma as compared to red cell mass. On the other hand, red cell mass is also increasing by 20 to 30%. How much? 1400 ml to 1700 ml. Again, learn these values. And again, they are mentioning the reason that there is a rise in erythropoiesis driven by erythropoietin and HPL. So it is also contributing in a rise in red cell mass. And we believe that red cells are important in delivering the oxygen to the cells of the body. So there should be a good mass in the female body. Hemoglobin and hematocrit. Hemoglobin concentration drops to 11.5 gram per 100 ml and hematocrit to 34% by 30 weeks. Again, this is known as physiological anemia. This is normal change and it's again peaking at the other hand, it increases. Okay, primarily the neutrophils, they increase after delivery, levels rise up to 25,000 leukocytes per mm cube. Now tell me guys, there is a question in Rico's discussion group. We are doing a question and it's giving you some features of anemia, also giving you this exact leukocyte count. Okay, and they are saying that the patient has, lower abdominal pain right after delivery. So a lot of students are picking up this question as sepsis. When I was discussing that question with you, students were saying that, ma'am, it's sepsis. And they said sepsis because TLC count is high and she is having lower abdominal pain. That answer was wrong, guys. I told you at that day as well that it's not sepsis. It's a normal physiological change in the body that the TLC count is increased, can be increased till this point, and it's normal. So we will treat the mild anemia and we will send the patient home. And mild anemia is treated with oral iron only. Okay, so don't treat the patient as sepsis. And that option was also wrong because they were saying give the antibiotic and send the patient home. Will you send sepsis patient home by just giving oral antibiotics? What do you say? No, you will not send the sepsis patient home by just giving oral antibiotics. So the protocol for treatment of sepsis is totally different. So understand the point of the examiner when they are giving you a question. You should know what they are asking and how you have to answer this. Okay, good. Now, guys, about platelets. Slight decline in platelets by term, we call it gestational thrombocytopenia. Platelet size increase indicating more immature platelets in circulation. And then iron metabolism. Iron demand is definitely increased with a total extra requirement of around 1000 mg. This is again as NSP you have to memorize. Pregnancy increases iron absorption but may still lead to iron deficiency anemia. And iron deficiency anemia is most common hematological problem during pregnancy. Okay, so you have learned a lot of SBAs here. Hemostasis in pregnancy is again very important. So they say that pregnancy is hypercoagulable state, and decreased fibrinosis. How it is hypercoagulable? Factor 8 is reduced, in 11 they remain unchanged. Fibrinogen level rise, doubling the erythrocyte sedimentation rate in late pregnancy. Routine coagulation tests remain normal with slightly shortened activated partial thrombo. Last in time, we have a person with open mic. Please, doctors, take care of this thing. Dr. Mariam Shabir, welcome in the group. And please mute your mic unless you want to speak. And we have antithrombin 3 levels. They remain stable due to increased production as plasma volume expands. Postpartum hemostasis, what is that? Fibrinolytic activity stays low during pregnancy and labor, but returns to normal after placenta delivery. Okay. Increased coagulability during the third stage of labor helps stop bleeding after delivery. So everything is there for a certain reason. Now, guys, another very important topic, the respiratory system. We will try covering respiratory system today, and then we will quickly move to GI changes and skin changes and urinary system changes. But this topic which I've opened is very important. For that, you have to learn the normal definitions of the lung volumes first. Okay, lung volumes and capacities, you have to learn that what is the normal definition. And we will again take help from a diagram. Okay, this is the diagram. This image is so important and it's very easy to understand. It's very easy to understand because it's showing that tidal volume is between this line. Inspiratory reserve is this one, and expiratory reserve is this one. Residual volume is not a part of this moving blue line, and we are leaving the rest. And now we are trying to understand what are the normal definitions of these volumes. So I've tried best to keep the definitions very simple, and let's read. What is tidal volume? You are breathing, but this amount of air will normal breathing. That's all. And what is residual volume? After normal breathing, guys, the air left in the lungs, it will always be present in the lungs after breathing. And if you are doing maximal expiration, it's again left in the lungs. So it will not let the lungs collapse. So we call it residual volume. Inspiratory and expiratory reserve volumes, we will read them. Extra air that can be inhaled and extra air that can be exhaled after a normal inspiration and normal expiration. Okay, let's talk about vital capacity now. Total air that can be expelled after maximal inhalation. FRC, an important one is the volume of air remaining in the lungs after a normal or tidal expiration, and inspiratory capacity is the maximum volume of lung of air that can be inspired after reaching the end of a normal quiet expiration. Now what you will do, I will give you this file. It will be with all the interested candidates who want to learn this physiological changes in the pregnancy. And other than core students, I can give you this file also just to help learning. You will memorize the definitions by taking help from this chart. Okay. By taking help from this chart, you will memorize the information. And again, what else you have to memorize? You have to memorize the changes in the pregnancy too. This image can be a little complicated, so we have simplified it by making a table. All the things, all the lung volumes which are decreased in the pregnancy, all the volumes which are increased in the pregnancy, and everything which is remained same is compiled in this table. This way that you can see FRC, TLC, RV, ERV, IRV, they are all decreased. We have tidal volume increased, respiratory rate a bit increased, ventilation a bit increased, sorry, 50% increased, and oxygen consumption 20% increased. And what is remained same, FEE1, vital capacity and compliance of the lungs. So what you will do, you will learn it by heart, and you will learn, they can ask you questions from this table, one thing from the respiratory, and they can ask you the definitions of normal lung volumes. These two questions are important. Okay, these two questions are very important. Should we move ahead? We should. Now we are reading the summary of respiratory change. Okay, the students who are joining now, you have missed cardiovascular system and the starting of respiratory system only. This is not much, but try playing the recordings because that part is very important. So ventilation is increased, guys. We have just learned. How much? 40%. They can ask you this thing. Why? Due to progesterone. We have studied, we are saying again and again that endocrinology, hormones, and pressure effects, these two things are giving you physiological changes of pregnancy. So progesterone is directly stimulating the respiratory centers and increases its sensitivity to carbon dioxide. Ventilation increases in the first trimester and continue throughout the pregnancy. Changes in the gas exchange, partial pressure for carbon dioxide, it falls to 4.1, and it's giving you mild respiratory alkalosis. Is this again a normal physiological change during pregnancy? Respiratory alkalosis? Yes or no? Yes, guys, respiratory alkalosis. All the students who are attending the recourse group, very good. Respiratory alkalosis is a normal physiological change in the pregnancy. Otherwise, it is not normal, but during pregnancy, this is a change. So 14 kilopascal is the partial pressure of oxygen, and it is increased. It's normal at term. Partial oxygen slightly decreases to 30 due to increased oxygen consumption and limited cardiac output. What about kidney compensation? To balance this mild alkalosis, increase bicarb excretion. This reduces serum bicarbonate to about 19 to 20 milli equivalent per liter. Sodium levels and osmolarity also decreases about 10 mmol. Is this understandable? Now we are moving to bronchial changes. Again, progesterone is coming and relaxing the bronchial smooth muscles, increasing airway caliber and reducing airway resistance. Breathing becomes more diaphragmatic than thoracic. Again, we have a question. We have a past paper question here. Lung volumes, tidal volume increases by 40, residual volume decreases by 200 ml, TLC decreases slightly by 200 ml. Vital capacity, it is unchanged. Vital capacity is total air exhaled from after full inhalation and remains unchanged, approximately 3.5 liter. Important information, and when it's given this way, it's easy to memorize as well. Lung and chest compliance, we learned that compliance. They're saying unchanged, but we have learned in the table that it is a bit decreased. Sorry, chest compliance. Chest compliance is decreased, lung compliance remains unchanged. Sorry, I misunderstood the point. Especially in the lithotomy position, again, because of gravid uterus and the diaphragm. Subjective dyspnea. How many times doctors, how many times patients are complaining about it? Dyspnea. Difficulty in breathing. Yes. They can use different words for this. When I walk, I'm short of breath. When I do house chores, I'm not able to catch my breath. Okay? They can use different terminologies for this, different layman terminologies. But how many times you have got this complaint from the patient? Yes, but pregnant patients, 70% they have written. And I've seen more than 70% because this is a normal thing, and also anemia is contributing to this. So every other patient is complaining about dyspnea. Every other patient. So they're saying about 70% of the pregnant women, they experience dyspnea or the shortness of the breath, even with normal lung function. Okay. Now, increased oxygen demand. Oxygen consumption increases by 50 ml per minute at term, reflecting the metabolic needs of the fetus, increased cardiac output, renal function, and overall metabolism. And there is another very, very important thing, risk of pulmonary embolism. It is decreased or increased. Pulmonary embolism. We just learned that pregnancy is hypercoagulable state. Hypercoagulable state. So the chances of this pulmonary embolism, they are good, very good, increased due to changes in the respiratory and cardiovascular symptoms. Very good, very good. If you have studied these two systems and you have learned the changes by your heart, and I've told you, if you are listening, if you are taking part in the conversation, there is 78 to 80% uh, re retaining power by discussing and by listening and by being a part of the meeting. So 70 to 80% of the times are you will not forget what you have learned. So these two systems are very important, guys. Physiological changes in the pregnancy. Now we will further read the changes in the urinary system. Again, important one, and we have 1 centimeter size of the kidney increased during the pregnancy. Okay, why it is increased? Because of increased renal blood flow and some other changes of the pregnancy. Ureter is also dilated. Again, the dilatation and resting and these kind of effects are mostly coming by the progesterone. Progesterone is responsible for making everything slow. Okay. P for progesterone, P for pregnancy, and S for slow. So now if you want to make this mnemonic, I keep saying that I don't like the idea of making the mnemonics because mnemonic is an extra burden on the brain to learn. But still, P for pregnancy, P for progesterone, and progesterone is making everything dilated, everything slow. So learn this way. So progesterone is coming and affecting on the smooth muscle, not only the smooth muscles of the ureter, it's affecting the smooth muscles of everything in the body. Wherever smooth muscles are present, progesterone is making them slow. Progesterone is making them dilated. It will not let the smooth muscle contract, especially in the uterus. So we will learn the changes in the uterus as well, not in this session, in the other one. So the mechanical pressure from the growing uterus and the progesterone, the both things I've told you, pressure effects and endocrinology. Everything is taking part in dilating the ureters. So it's increasing the risk of what? UTI and the potential progression of pyelonephritis. And now you will tell me how many times you have seen patients with UTI, pregnant patients with UTI. Yes, how many times? It's quite common. It's quite common. Yes. Almost every patient complains about having UTIs. What about renal blood flow and GFR? Both increase. They both increase and by 50 to 60%. GFR, the normal value is 140 and it's reached to 170 by a gram. Biochemical changes are also important. Urea, it's decreased from 4.3 to 3.1. Creatinine decreases from 73 to 47. Urate and bicarbonate levels are also decreased. Sometimes we see mild glycosuria. It's a it's not very common, but it can be a normal finding due to increased GFR and renal changes and some degree of proteinuria, which is otherwise not a normal thing at all, but due to increased GFR renal changes, patient is normal, not having anything bad happening, but still she can have glycosuria and proteinuria. Plasma osmolality, again, guys, it decreased due to progesterone effects and alterations in the renin, angiotensin, aldosterone pathway. Now we're talking about GI changes. Nausea and vomiting. Again, you will tell me, is this a common finding in the pregnancy, especially in early pregnancy? Yes, obstetrician and gynecologists doing their OPDs in early pregnancy. Again, nausea and vomiting is so common that if somebody says that I don't have nausea and vomiting in early pregnancy, we find it abnormal because it's quite common and it's quite normal. And it is caused by the raised level of beta HCG in the starting and also some degree of progesterone is also contributing. Reduced GI motility. When GI motility is reduced, again, I've told you the culprit for every change, the culprit for every change is progesterone. So it decreases the tone and the motility of the smooth muscles of the GI tract. It leads to delayed gastric emptying, especially during labor. What happens? It also relaxes the LES, lower esophageal sphincter, and it is increasing the risk of acid reflux and heartburn. Heartburn affects 81% of pregnant women by term. Documented number is 81%. I have seen every other patient complaining of heartburn and reflux and constipation and you know GI discomfort. Now, there is increased risk of aspiration during general anesthesia as well due to delayed gastric emptying, which is a serious concern. And aspiration of acid gastric contents can lead to Melanin syndrome, severe pneumonitis. When you are giving anesthesia to patient, this can contribute to a serious concern. Further, guys, we have to learn about the gallbladder motility, reduced motility due to decreased cholecystokinin levels can increase the risk of gallstones. Okay. Constipation is very common. Decreased bowel motility results in longer transit times, causing firmer stools and constipation. Changes in the liver function, we can see alkaline phosphatase. It increases due to placental production of ALP. This is a normal thing. We have seen a lot of SBAs I've shared in the study room as well that alkaline phosphatase, it's a normal change in the pregnancy that it increases. Risk of obstetric cholestasis, not a normal thing, but a pathological condition in the pregnancy, liver condition with itching, raised liver enzymes, and bile acids. Okay. Obs cholestasis is linked to increased risk of fetal distress and intrauterine fetal death. So it's a pathological condition. Remember, drug absorption and metabolism in pregnancy. We should also keep this thing in mind that gastrointestinal absorption is slow, impaired by gastric stresses and reduced gut motility. So lower gastric pH may also affect absorption of some drugs. So if a non-pregnant patient is taking a drug and a pregnant patient is taking a drug, gastrointestinal absorption may be slow in the pregnant one. Plasma volume is also increased. So volume of distribution is now large. Volume of distribution for a drug is now large and because of pregnancy, increase in the plasma volume. So drug concentration may be lower than expected, especially for drugs like anticonvulsant and thyroxine. So what we do, we change the we change the dosage of the drug accordingly. Renal excretion is also affected. Increased GFR leads to faster excretion of the drug, primarily excreted by the kidney. And dosage adjustment are very important. Changes in the drug metabolism during pregnancy often requires dose adjustments for effective therapeutic levels. Skin and other physiological changes in the pregnancy. Now it's very important to learn them as well. And this is the last point we are discussing. After that, we can close this session. We can have question answer session after this topic as well. So hyperpigmentation is very, very common. Why it's very common? Because of increased melanin production and it's causing darkening of the skin, especially the areas nipple, areola, linea nigra. It's the dark line on the abdomen and face plasma or melasma or the mask of the pregnancy. In the workshop, guys, the workshop is coming in the January, and I have added a lot of questions with images because our COG loves to share the questions with the images. They will give you a picture of a patient having the mask of pregnancy or plasma, and they can ask you why it's happening to the patient, why this hyperpigmentation is happening to the patient. So what you will say, it's because of high melanin production. Now, stria gravidarum, which is in common terminology, we call them stretch marks. Overstretching of the abdomen, breast, and thigh because of rapid weight gain. We have these lines on female body. They start as reddish or purple streaks, and further they are silvery white in color. Okay. Vascular changes are very important. Increased vascularity lead to spider veins, telangiectasia, and palmaroedema. Not so common, but still some women experience varicose veins also due to increased blood volume and pressure on the veins from the growing uterus. Nail and hair changes are also important. Hair growth may increase due to hormonal effects, but postpartum hair shedding is very common. We call it telogen effluvium. Nails may become more brittle or grow faster during pregnancy. That's all. That's all. I have tried my best to cover major physiological changes from all important parts, from all important systems. And I will provide these files to you, inshallah. Students, you can contact me on my number for taking these files. And if you are done with this session, you are sitting here with me and discussing, and you are trying to absorb the information. And further, right before exam, if you only give 10 minutes to this file, you are able to revise it very quickly. Okay? Is there any question, guys? Is there any question? Okay, dears. I really wish that you find this session and discussion helpful. And let's close the meeting now. If you have any question regarding this topic, if you have any question regarding exam, you can share in the discussion group on the WhatsApp. And for students, now they will study the past papers after 2 hours, inshallah. Okay, bye bye. Take care.